Back to my sessions on pediatric topics. Today I'm going to talk about another very common topic, a simpler topic, which I'll start with a case basically. And this is a case which I have seen during my PG days, and this was my first duty in my NICU, and this was a 4-day old preterm baby. Okay, and he was a male baby of MR. I won't want to reveal the names. The baby's birth weight was 1.3 kgs. He was referred to me by a peripheral NICU to my tertiary care NICU, and the reason they had stated was the baby requires ventilation and was referred for that. And at admission, when I saw the baby was sick. Okay, the baby was sick. The baby was hypothermic. Sorry. Baby was sick, baby was hypothermic, and baby was cyanosed. All right, poor capillary refill. All right, the capillary refill was almost 5 seconds, and the respiratory efforts were not proper. Heart rate was less than 60. All right, SpO2 was 43%. All right, at room air, and GRBS was 66 milligram per deciliter. So we immediately initiated the resuscitation as per the protocol. The baby was intubated, connected to a ventilator, and shock was corrected, bolus was given, inotropes was started, and everything. And this was, the baby arrived to us at 2:30 a.m. in the night. All right, and by roughly around 3 a.m. we were successful in stabilizing the baby more or less on the ventilator and inotropes. His heart rate came up to 132. His SpO2 was 94 on the ventilator, and CFT became 3 seconds, roughly 3 seconds. All right, so our treatment was working. So within half an hour roughly, we have stabilized the baby's vitals by doing active resuscitation, and we have given correction of the shock with bolus, inotropes. All right, then what happens is we put in an OG tube, and from the OG tube we have aspirated, but there was there was light brown aspirates. We did not feel much of a concern at that time, but at 4:30 a.m. the baby suddenly started showing profuse bleeding from the ET tube. Even the oral mucosa was bleeding, and when we aspirated the OG tube, then there was 8 ml of fresh blood. All right, and then we immediately started giving the baby in vitamin K injection, and we got a cross match sample done. We sent it to the blood bank. By 5:15 a.m. we had given the baby a Ffpe. All right, and but still the baby is still very sick, very sick. By 5:30 a.m. the bleeding is continuing from the ET, from the OG tube, and from the mucosal surfaces. The baby is continuously bleeding. There's no stoppage of bleeding whatsoever. All right, and then we are like, okay, this baby is bleeding a lot, we need packed cells along with another Ffpe, okay, if possible. And then we are planning for that same, but at 5:40 p.m. the baby goes into bradycardia. Again cyanosis developed, CPR was started, adrenaline was given, and the baby continued to deteriorate. At 5:45 a.m. the baby went into arrest. All right, and the baby could not be revived, and we declared the death at 6:10 a.m. after the ECG was done, and we confirmed all the vital signs were not there, and that death has happened. So we came with a diagnosis, as most of the postgraduates would have guessed. We can make a wild guess. It's a septic shock, there is a respiratory failure, and there is DIC. All right. So my topic for today is going to be about a very interesting finding in an NICU, where you see a bleeding neonate. Okay, so we are going to talk about what is the approach to a bleeding neonate. Now the bleeding can be any kind of bleeding. It need not be the bleeding what I have described. It can be a bleeding of any kind. But what is the approach? Like, how do we go about this approach to a bleeding neonate. So like always, I'll be dividing the approach to a basic divisions. Like first part, I'll be talking about history. Second part, I'll be talking about examination findings, anything related to the examination. Then I'll be talking something about investigations. Okay. And last but not the least, I'll talk a little bit on the management of few common causes of a bleeding neonate. Okay, so let's begin. All right. So history. So what do we do in history? So history, like always, we know in the NICU, the history starts from the mother. So let's talk a little about maternal history, which can be important for a bleeding neonate. All right. So first thing, some underlying maternal illnesses. Underlying maternal illnesses. What are those? Like preeclampsia, cardiovascular disorders, viral infections, all right? Or any drug history in the mother. Like if mother has taken aspirin, anticonvulsants like phenobarbital, phenytoin sodium, or any anticoagulant medications, all right? Or the mother herself is a known case of some disorder, known history in mother of certain disorders like collagen vascular disorders, all right, or past history of ITP in the mother, all right. So all these could be a contributory factor to the bleeding in the neonate, all right. Then next, coming to birth history. So what do you want to know in the birth history which could be related to a bleeding neonate? We would want to know the type of delivery, okay, type of delivery. We would want to know about if any birth asphyxia was there, any trauma was there, all right. We should even note down the gestational age, whether it's a preterm or a term, all right. And very important is history of vitamin K injection given or not. Was vitamin K given to the neonate or not, or antibiotics were given, any antibiotics which could cause the vitamin K depletion or any other effects on the bleeding mechanisms, and whether the neonate received breastfeeds or anything else like formula feeds, all right. So we want to know regarding all these things related to the birth history. Coming to the next one, family history. Family history. This family history is suggestive of bleeding disorder or not. So sometimes what happens, there is excessive bleeding after an injury in the family. There will be history like that, or there will be history of menorrhagia in the female members in the family. All right, and also 3-generation pedigree again here is important, okay, because some genetic disorders may present with a bleeding in the neonatal period. So for example, X-linked inheritance can be seen in factor 8, factor 9 deficiencies, okay, where you will see a similar history in the bleeding episodes in the male siblings or maternal cousins or maternal uncles, all right. Autosomal dominant can be seen in von Willebrand's disease, dysfibrinogenemia, hemorrhagic telangiectasia, and then autosomal recessive also patterns can be seen in some factor deficiencies. So we need to inquire for consanguinity in this. All right. So we have gone through few aspects of history, that is maternal history, birth history, and family history. So these are the important aspects of history. Now then, coming next to examination. Okay, we'll discuss a bit about examination. Now, the first thing you need to assess in a bleeding neonate, as soon as you get to know that there's a bleeding neonate in your NICU, you should categorize whether the baby is well or sick. Okay, so that is an important aspect of your assessment in examination. Immediate rapid thorough assessment should be done to divide the baby into well or sick, because the causes are different in both. So I'll just list out the basic ones here. The well baby can have an HDN, all right, or it could be an inherited deficiency of any coagulation factor, okay, coagulation factor deficiency, or it could be an isoimmune thrombocytopenia, all right, it could be a platelet function disorder, vascular causes, slippage of ligatures, all right, or swallowed maternal blood syndrome, okay, swallowed maternal blood syndrome. In a sick child, You could consider diagnoses like sepsis, very common, asphyxia, which could be related to or not related to prematurity, liver diseases, okay, some liver abnormality, severe acidosis, okay, which can be present in shock, and DIC. Okay, DIC is also very important differential diagnosis. All right. Now, once we have classified the baby as well or sick, and you have a rough idea about what could be one of the differential diagnosis, we could know, like to know what is the site of the bleeding. Okay, this is very important. From which site is the bleeding happening? Bleeding from, for example, umbilicus in a healthy child without any evidence, without there is umbilical bleeding, and there is no sign of umbilical sepsis, there is no sign of slip ligature, you could suspect something like a factor 13 deficiency, okay, or hypofibrinogenemia, or dysfibrinogenemia. All right. Or for example, bleeding from a site of circumcision in a male, okay, circumcision, or a hematoma at injection site hematoma in a healthy child, you could suspect factor deficiency or HDN. All right. Bleeding from GIT, so you're getting like OG bleeds, all right, or you're getting a blackish colored stool which is not melena, you're suspecting it to be some bleeding from the GIT. Okay, this could be due to swallowed maternal blood, or something like vitamin K deficiency bleed, which could also come from the GIT. If there is a sick child and there is mucosal surface bleeding, mucosal bleeds like from the oral mucosa, from the nasal mucosa, from the anal mucosa, all mucosal surfaces are bleeding, sick child, DIC is a very important differential. All right. And for example, a big cephal hematoma following a normal delivery, okay, a big cephal hematoma, there's a cephal hematoma which is big in size, okay, and it was a normal delivery, and it was not a prolonged labor, it was not a difficult labor, it could be an inherited bleeding disorder. All right, inherited bleeding disorder. Then now there is a presenting part after in the delivery, in the process of labor, there is a presenting part. If there are petechiae or ecchymosis on the presenting part, this happens due to secondary to congestion or birth trauma. All right, and this will be seen soon after birth, but they gradually disappear, and then the bleeding won't be there. There won't be any other bleeding manifestations. So this is congestion and birth trauma related only in the presenting part. But skin bleeds, if there are present, like purpurea, petechiae in a healthy child, okay, a healthy child, in a healthy baby, you are seeing purpura, petechiae and skin bleeds, you can suspect immune thrombocytopenia. All right. And very important differential of this in an NICU is mosquito bites. Okay, you need to differentiate this from a mosquito bite. Okay, so sometimes there will be mosquito bites in the NICU, and the next day you come, you have your duty, and the next day you come and see the baby is all having like this red spots, healthy baby, all right, and no problem, feeding is well, all vitals are stable, the baby is active, crying, and you see the spots, okay, and all your parameters are normal, even your thrombocytes are normal. So you have ruled out immune thrombocytopenia, and this could be nothing but mosquito bites. For a very easy clue, try to look at the parts which are exposed. For example, inside the diaper area, they won't be having the mosquito spots, or if the baby is, suppose, let's say, wearing clothes also, so inside the clothes there won't be any bleeding, there won't be any mosquito bite marks. The mosquito bite marks will be only in exposed areas. So you can rule out in that way. Now, next thing in examination which you would like to look for is any associated systemic findings. Okay, associated systemic findings. What are the associated systemic findings? You can see very important is hepatosplenomegaly associated with jaundice, and there may be chorioretinitis. Chorioretinitis. Any clues? Any from these clues are you able to tell? There is a bleeding neonate and there is HSM, jaundice, chorioretinitis. Very common cause, very common cause, torch infections. Torch infections, okay? Then rarer causes which should also be considered if a similar presentation is there, is erythroblastosis fetalis and leukemias, neonatal leukemia, which is very rare, quite very rare. Okay. Associated systemic findings are over. Associated syndromic findings. There are some syndromes which may present in the neonatal period as a bleeding neonate. Now there is something called as Viscot-Aldrich syndrome. Viscot-Aldrich syndrome has a triad: thrombocytopenia, eczema. All right. So in Viscot-Aldrich syndrome, you will see eczema in the child, eczema in the baby. Okay. Now there are some radial rim anomaly star syndrome, which is absent radius with thrombocytopenia. So this can also have a bleeding manifestation. Now a very characteristic finding, which even in Robbins we have, there's the one point which he discusses in Robbins, even in DIC, a large hemangioma which is associated with DIC, Kasabach-Merritt syndrome. So look for Kasabach-Merritt syndrome. Okay. And sometimes now there is some syndactyly you've seen and there is bleeding. You can suspect factor V deficiency. Okay. And last but not the least, there is something called Ehlers-Danlos syndrome, which presents with, hyperelastic skin and all that. It will even have some bleeding manifestations like ecchymosis, bruises, purpura. Okay. So these are all syndromic associations of a bleeding neonate. Okay. Now next, what we would like to see is the investigations. All right. So our examinations are done. Now I am going to discuss few investigations. Now the first thing you have to confirm, is it actually really a bleed? Is it a bleed or is it just a normal baby with maternal swallowed blood syndrome? Okay. So specifically when the cause is GIT, you have put an OG tube and you aspirate and you see some reddish colored blood or brownish colored fluid, and you have to suspect whether there is maternal blood swallow syndrome, especially in the early newborn period. So this first thing is you have to rule out whether it's maternal swallowed blood syndrome. Okay. This happens in the early newborn period and there are two causes for this. What are the two causes? First of all, the swallowing of the blood, basically two times it can happen. It can happen during the delivery or it can happen during feeding after the birth. During the feeding, due to the cracked nipple, okay, some mother's nipple, breast nipple is cracked, there is bleeding from that and baby is swallowing along with the milk, so he may have bleeding neonate manifestations. And during the delivery. All right. So these are important. So what can be done to rule this out? Okay. Now there is a simple bedside test called app test. This app test can be used to differentiate between a maternal swallowed blood syndrome and a real bleed from a GIT. All right. Because the principle of this being, in this we use a alkali actually, and alkali will denature an adult hemoglobin but will not denature a fetal hemoglobin. The HbF is resistant to denaturation by alkali, whereas adult hemoglobin present in the mother's RBCs will denature with alkali. So in this, what you do is you take one part of the vomitus of the baby and 5 parts of saline you will mix, and you centrifuge at 2000 rpm for 10 minutes. All right. Then you add 4 ml of 10% NaOH to 1 cc of supernatant centrifuged fluid. Alright. If there is brown color, it indicates it's maternal blood, and if it's pink color, that is it's resistant to the denaturation, it indicates fetal blood. Okay, so this is a simple test. So this is about the maternal swallowed blood syndrome and app test and everything. Now what are the basic investigations which we are going to go and do in the case of a bleeding neonates? First, obviously you will go for a hemogram checklist. This is a checklist: hemogram, complete hemogram. All right, peripheral smear examination, peripheral smear. All right, then coagulation studies, that is PT, APTT, INR. All right, and BTCT. So these are some tests which you will be doing, and there are normal values which you will have to there are reference values which you will have to refer, because in a neonate it keeps changing. For example, at birth the normal HB, like normal hematological values which you need to know, at birth you will have hematocrit of 53, HB of 16.8 roughly, okay, in term infants, and by day 14 it will become, HB will become 50, hematocrit will become 52, and HB may even become up till 16. So that is normal. So you need to know what are the changes which are going to happen in the normal hematological value changes in the first 2 weeks of life, at least in a term baby. If you have a table in front of you which you can refer to, any pediatric hematology textbook will give you that, and you can make out whether there is any abnormality in the hemogram. So always in the NICU you should keep referring to this when you are seeing a hemogram in an NICU, because you just cannot correlate it with an adult value or a normal child values also. Now I'll just give you a small table of these important ones. There is PT and APTT and PT and okay, sorry, PT and APTT, okay, and there is a full term and there is a preterm, full term and preterm. In preterm, the PT in a full term, the PT in seconds is 14 plus or minus 1.3, and APTT is 51 plus or minus 10. Okay, and in a preterm child, it's the same, 14 plus or minus 1.3, whereas APTT becomes 57 plus or minus 10.5. So this is just a basic reference which you should be knowing these, because if you don't know these, then what are you comparing your standards with? So once you know this, you are able to make out whether the PT APTT values are abnormal, and you'll be able to go further in your findings. Now some detailed discussion on how the findings of the various diseases will be. So first let's go with platelet disorders. Okay, the platelet disorders. So in platelet disorders, so let's say there is a case of thrombocytopenia, and there is a normal PT, normal APTT, okay, and there is a healthy newborn, so that is well neonate. So this could mean three things, okay. So either it could mean a very common is an alloimmune or autoimmune thrombocytopenia, all right, and rare is Kasabach-Merritt syndrome and a bone marrow hyperplasia, okay, bone marrow hyperplasia, these both are rare. So common is autoimmune or alloimmune thrombocytopenia, in which there will be only thrombocytopenia, normal PT, normal APTT, and healthy newborn, like we discussed earlier. And if you are suspecting autoimmune thrombocytopenia, the mother's platelet count should be done, in which she may have thrombocytopenia, and then you have to rule out something which is called as chronic ITP in the mother. All right, and even the same, test the mother for collagen disorders, collagen vascular disorders, and ANA profile to rule out any other autoimmune manifestations, autoimmune diseases. If you're suspecting alloimmune thrombocytopenia, in this the mother's platelet count is done, and this will reveal a normal count. Mother's platelet count will be normal, and there is something called as a platelet antigen, PLA1 antigen. Okay, platelet antigen. This should be studied in both the mother and the baby. The mother will be PLA1 antigen negative, whereas baby will be PLA1 antigen positive. So the baby is having an antibody. In this, there is alloimmune, neonatal alloimmune thrombocytopenia, which is called as NAIT. Okay, neonatal alloimmune immune thrombocytopenia. Now coming to the other platelet disorders, like low platelet count. There is a low platelet count. Okay, these are all scenarios which I am telling you so that you can understand, and then I'll summarize everything in a table so that you get a clarity. So don't worry about it. There is a low platelet count, there is a normal APTT, and there is a normal PT. So this could be nothing but platelet consumption in a sick child, in a sick baby. This is in a sick baby. So this is could be a platelet consumption. Now, when does platelet consumption happen? Platelet consumption can happen in something like NEC or septicemia. Okay, NEC or septicemia. Now, if there is a low platelet count but raised PT and raised APTT, all right, prolonged PT and prolonged APTT, and again there is a sick baby. So what are your differential diagnoses? DIC. That is what you are thinking, DIC. So how will you confirm whether it's DIC? Like, are there any confirmatory tests? Is there any way to tell, okay, this is DIC? Yeah, there are a few methods which can prove. In a peripheral smear, like I said, we told, right, all the checklist. In that we did peripheral smear, right? So in a baby who's having DIC, in peripheral smear you may see Burr cells. Okay, you may see broken RBCs. Okay, and you may see something called as helmet cells. Okay, what happens to the serum fibrinogen? Serum fibrinogen is decreased in DIC. And what happens to the fibrinogen degradation products? Increased. Okay, so this is a way to tell, okay, this child is having DIC. So this is about the platelet disorders. So I have told you about the normal platelet, platelet disorders. We have told about the thrombocytopenias with normal PT APTT in a healthy newborn, thrombocytopenia with normal APTT PT in a sick baby, and a thrombocytopenia with prolonged APTT PT in a sick child. Okay, so now we'll be going to the coagulation disorders. Platelet is over. Coagulation disorders. So I'll summarize everything. Don't worry. Okay, just understand what I'm trying to tell now. So in the first scenario, now these are all coagulation disorders. So these will have no platelet abnormality. There's a normal platelet count, and there is prolonged PT or APTT, and the child is healthy. So what are we suspecting? There are two differential diagnoses. Either the baby is having vitamin K deficiency, or there is a defect in common pathway, coagulation pathway. Common pathway defect. Okay. Now in this, if you are suspecting in this way, if you give vitamin K to this baby, what will happen? It will normalize the PT and APTT. So this will prove that this is HDN due to vitamin K deficiency. If this is not happening, if this is not what is happening, therefore it is a defect in the common pathway. So for what do we do for defect in the common pathway? Now there is a defect in common pathways. Okay, fine. You have understood that there is a normal platelet count, prolonged APTT and prolonged PT and healthy newborn, and you are saying okay, it's a defect in the common pathway. And you have given vitamin K and it did not get corrected. So you have, okay, fine, there's a defect in common, but what in the common pathway is affected? We don't know. So for this, the tests which are useful are thrombin time, to further classify thrombin time, and serum fibrinogen concentration. Alright, so we'll be doing these two. So from this we are able to tell what is the problem. So let's say the serum fibrinogen, which I'll write as S, serum fibrinogen is low, alright, and prolonged thrombin time. The thrombin time is prolonged and the serum fibrinogen is low. Then this will say it is hypofibrinogenemia. Alright. Now if serum fibrinogen is normal, but prolonged thrombin time, there is prolonged thrombin time. So basically the fibrinogen is not functioning properly. So what do you see? It is called dysfibrinogenemia. And some other causes are presence of inhibitors, heparin, okay, etc. All these are the causes. Now coming to more coagulation disorders. Sick child, the child is sick, platelet count is normal, and PT, APTT are prolonged. Sick child, so what can you suspect? Can you suspect liver disorder? Yes, you can suspect liver disorder. And what do you do to confirm? You will do a liver function test. Okay, now there is a sick child, sick baby, normal platelet count, normal PT and normal APTT. So this could be nothing but stress bleed. This is called a stress bleed. What is a stress bleed? A stress bleed is a bleed which occurs in any baby who's sick. You're sick, a neonate who's sick may bleed. In that baby, the platelets will be normal, the PT will be normal, and the APTT all will be normal. All right. Now next, coming to more, I have to discuss more coagulation factor defects. There's a normal platelet count. There's a normal PT, but there is increased APTT, and the child is healthy. Means what? I always remember it this way: PTE, prothrombin time is extrinsic pathway, so and APTT is intrinsic pathway. So what is this? This is an intrinsic pathway defect. So what are the causes of the intrinsic pathway defect? Hemophilia A, hemophilia B, hemophilia C. Alright. So for this confirmation, what can we do? Factor levels, factor assays. Okay, we can do the factor assays to confirm what is the level, and we can do correction studies, serum correction studies, pool serum correction studies. So from that, this the APTT will be corrected by adding a normal human serum. Okay, so normal human. Okay, and then next, coming to normal platelet count, normal APTT this time, but prolonged PT, and the child is again healthy. Okay, so I told you PTE, so thrombin time is extrinsic pathway. So in this is an extrinsic pathway defect. So most common extrinsic pathway defect is factor 7 deficiency. So in this, you will be again doing the correction studies and the factor assay level, to know the diagnosis. All right. Okay. Don't get exhausted. I'm very sorry if this presentation is going a little exhaustive, but at the end I'll summarize everything. Okay, so don't worry. Now I'm going to again talk about what I've already told these few things, but I'm going to talk about it again. There is a normal platelet count, there is a normal PT, there is a normal APTT. Okay, these 3 points. What are all the differential diagnosis? Number 1, swallowed maternal blood, or traumatic bleed. Very sorry, swallowed maternal blood or traumatic bleed. In this, what you'll be doing, baby is observed and there will be no reoccurrence. All right. And then there are qualitative platelet disorders. Qualitative means functional. In this, what will happen? In this, bleeding time will be more and there will be poor clot retraction. And in this, you have to go for aggregation studies. All right, aggregation studies. Next, if there is factor 13 deficiency, you will have a similar manifestation. Similar, this is the one I'm talking about. Okay, factor 13 deficiency, you will have to go for urea solubility test. If you are suspecting something like Ehlers-Danlos syndrome, okay, genetic studies, you will have to go for genetic studies and clinical examination for elasticity and all that. All right. And if you are studying hemorrhagic telangiectasia, if you are suspecting, you should see for telangiectasia in the mucous membrane of the nose, the bulbar conjunctiva, the tongue, the tips of fingers, and this also needs further genetic studies to confirm. All right. Now at this juncture, I will want to show you one photo. It's nothing much, but just a flow chart, just a table. It's very easy. Now you know everything. So this is actually the end, the outcome of the entire presentation, which you need to understand is this. So your assessment first is to identify whether, first you have to identify whether the child is sick or whether the child is well. Okay, after you have seen whether the child is sick or child is well, look at the platelet count. Is the platelet count normal or is it decreased? Is the platelet count normal or is it decreased? Okay, now after knowing if the platelet count is normal or decreased, if the platelet count is normal or decreased, you are again looking at the PT and APTT. See, sick neonate, thrombocytopenia, and normal PT and APTT is sepsis or NEC. Okay, sepsis or NEC. Sick neonate, normal platelet count, and normal PT and APTT is stress bleed. Okay, understood? I'm talking about all the, I'll talk first about all the ones in which PT and APTT is normal. A well neonate with thrombocytopenia, but normal PT and normal APTT is immune thrombocytopenia, Kasabach-Merritt syndrome, and bone marrow hyperplasia, in which this is the more common one, and Kasabach-Merritt and bone marrow hyperplasia are very uncommon. And then there is a normal thrombocyte level. There is no thrombocytopenia. It's normal platelet count in a well neonate. Okay, and again both are normal. PT and APTT are normal. Healthy child. It could be a swallowed maternal blood, qualitative platelet defect, factor 13 deficiency, like I discussed the differentials. Okay, then next coming to sick neonate with thrombocytopenia and increased platelet and increased APTT is DIC. Okay, whereas a sick neonate with normal platelet count with increased PT and increased APTT is liver disease. all right. And a well neonate with normal platelet count and increased PT, increased APTT could be a vitamin K deficiency bleed. And in this, if you give, I'm so sorry, in this, if you give vitamin K, the bleeding will be stopped. And if the child is having a prolonged APTT, it is a problem of the intrinsic pathway. If the same was there, in which there would be this was increased and this was normal, it is an extrinsic pathway defect. Okay, so this is the summary which you need to know, okay, of this present class. Okay, one second. So now you're done with the approach. Now I will be telling a bit about the management. All right. The management of the cases. Now, first let's say, is there a way to prevention of bleeding in newborn? Is there a way? Yes, there is a way. That is, first of all, you can give something called as vitamin K. This vitamin K is given at birth, okay, to all babies, okay. Those who are above 1.5 kgs, we will give 1 mg. Those who are below 1.5 kg, we will give them 0.5 mg. Okay, we should give compulsory to all babies. Now, to who else can we give vitamin K? Can we give any other time also to vitamin K? Yes, 1 mg vitamin K can be given weekly, or should be given rather, to any babies, any neonates who are on total parenteral nutrition, on broad spectrum antibiotics, and who are sick neonates. All right. Another method to prevent is to mothers who are on phenobarbital, phenytoin, antitubercular drugs, or coumarin drugs. All right, you can give 10 mg vitamin K, IM or IV, to the mother 24 hours, minimum 24 hours before the delivery. So this will help to prevent the bleed in the neonate. Okay. Now coming to, this was prevention. Prevention is over. Okay. Now we'll go to treatment. Okay. Treatment of a bleeding neonate. Now there are some general principles I would like to discuss first. So in the general principles of management, first you need to do is, you need to give vitamin K. Vitamin K 1 mg should be given, if not already given, in the preceding week. Okay, first thing to note is vitamin K. Second thing what you need to do is, you need to get cross match done. Immediately get a sample of the child to get cross matched. For getting an emergency transfusion and further transfusion, you need a cross match. Okay, if suppose there is a hypovolemic shock or blood loss which is more than 10%, you need to give equal amount of blood, whole blood, or a plasma expander. Okay, and then you should look for the underlying cause and treat the cause. These are the general principles of management. Okay, now talking a little bit about the platelet transfusion. When is it indicated in a bleeding neonate? When do you indicate a platelet transfusion? Now this is based on the count. I'll just make it clear for you. So if the count is less than 50,000 per mmq, in what conditions of thrombocytopenia less than 50,000 do you give platelet transfusion? So the first condition is any preterm infant in the first week of life, less than 33 weeker preterm infant in first week of life. Okay, any clinically unstable term infant in first week of life, any neonate undergoing an invasive procedure like ventricular tap or LP. If having less than 50,000, you should transfuse. And any preterm neonate who has to be started ibuprofen or indomethacin, okay, like in PDA we'll start, right? He has a PDA, his platelet count is 30,000. So do you give a platelet transfusion before starting ibuprofen and indomethacin? Yes. And who has had a recent onset grade 3 or grade 4 IBH. All right. So this is when to give when the platelet count is less than 50,000. When to give when the count is less than 20,000 per mm cube. This is for all infants, even stable infants. All stable infants beyond first week of life. Beyond first week of life without active bleeding. So even if there is no active bleeding and the first week of life has passed and platelet count is less than 20,000, you can transfuse platelets. Now for LP, let's make a note for LP. For LP, more than 10,000 is safe for performing an LP if the baby is stable and is not bleeding. Okay, so in that conditions you can give, okay, and well, not bleeding, you can do LP, okay, in a thrombocytopenia case. This was just a side mention. If the count is less than 1 lakh per mm cube, when do you transfuse? You have to transfuse, but in what condition? When there is a neonatal alloimmune thrombocytopenia. If there is a neonatal alloimmune thrombocytopenia with platelet count less than 1 lakh, you can transfuse. And if the count is less than 1 lakh, again 1 lakh, and there is an active major bleed, active major bleed, you can give a transfusion. And if there is a qualitative platelet defect, and there is bleeding, at any platelet count, you can give a PRP transfusion. Okay, all right. Now little bit details about the instructions of the platelet transfusion. This is going into details of the management, so I wanted to complete everything in the one video. So I'm just going to tell you the basic instructions for platelet transfusion. The transfusion should be done at 10 to 15 ml per kg over 1 hour. Okay, and this will approximately raise the platelet count by 60,000 per mm cube. The packet must be kept in room temperature only, and you should start the transfusion as early as possible after the arrival of platelets from the blood bank, because you don't want to risk what? Aggregation. Okay, and before starting the transfusion, you should gently swirl the bag. Okay, gently swirl the bag, and you should avoid transfusing through a central line. Okay, central line, avoid transfusion because there can be thrombosis. Okay, and this, though you know, like baby blood group is O, what would you want to transfuse? Platelets O. What are the other preference you can give? B. First preference, second preference. If the baby is A, you need to give A, second preference is AB. And if the baby is B, the first preference is B, second preference again AB. If the baby is AB, first preference is AB, second preference can be B or A, anything is okay. Okay, these are some guidelines of transfusion. Okay, and what are the indications? This was about platelets. Now what is about guidelines for Ffp transfusion? So Ffp, when do you give Ffp? Ffp can be given in any coagulopathy with bleeding, Okay, it can be given any coagulopathy with invasive procedure planned. Invasive procedure is planned. Okay, and for factor replacement, when concentrates are not available, like factor 2, factor 5, factor 10, factor 11, for that you can give, and at initiation of heparin therapy. So the few guidelines for the for FFP. FFP again, first preference, second preference. Okay, for FFP, O, A, B and AB. If the baby is O, give O. Second preference can be anything, can be given. If A is available, A, B is available, B, or AB is available, AB. Okay, you need to remember the basic guidelines where the antigens are present and where the cells are present. All right, serum, packed cells. So all this is important. So FFP is just plasma. So you should think about the antibodies. Okay, so A, again A, and you can give only AB, and the same way B carrier you can give only B and AB, and for AB you can give only AB. There is no second preference. All right. And what are the instructions for FFP? This also has to be given 10 to 15 ml per kg and within 4 hours of thawing. Thawing means that frozen plasma will become liquid. Okay, with active bleeding, one may need to raise the concentration of the clotting factors to increase 20% of the normal. Okay, this can again be done by repeating a 10 ml per kg. Okay, and transfusion should complete within 30 to 60 minutes. Within 30 to 60 minutes should complete it. And once you have thawed, transfuse immediately. Do not refreeze. Please, house surgeons, do not refreeze. Do not be, sister, where is the NICU fridge? We'll store this. You have already made the entire FFP into liquid, then you're going and putting it in the freezer and then you're again taking out. No, not allowed. Do not refreeze. Okay. Next, a little bit about the way other managements. Management on immune thrombocytopenia. Immune thrombocytopenia. Screen the baby's platelet count soon after birth if born to a mother with immune thrombocytopenic purpura. Especially mother who is having ITP should screen the baby's platelet count. In case of an alloimmune thrombocytopenia is found, you can give washed platelets. Washed platelets of the mother, resuspended in plasma or from a donor who is PLA negative, that is HPA1A negative. Okay, you can do this, and you have to administer when the neonate has counts less than 30,000, irrespective of bleeding. If minor bleeding is there, between 30,000 to 49,000, and if there is major bleeding, you can give between 50,000 to 99,000. I don't want to go in more details of that. Let's keep that aside. IVIG can be given at 0.4 grams per kg per day for 5 days or 1 gram per kg per day for 2 days. Okay, and you can even give prednisolone, which is an alternative, at 2 mg per kg per day. Okay, what about DIC? What about DIC? How do you manage DIC? First, treat the underlying cause of the DIC. Give vitamin K, 1 mg stat IV. Okay, IV stat. Platelets and FFP can be transfused as and required. Okay, to keep the platelet count should be above 50,000. Okay, you can consider double volume exchange transfusion if bleeding is persisting. In case of thrombotic DIC, you know what is there is two, right? Like Robbins beautifully describes DIC as cell of rabbits. So there is one side when there is bleeding diathesis going on, and one side there is thrombosis going on. So if there is a thrombotic DIC, you can give heparin at 30 international units per kg IV stat. This is heparin. Okay, you can give heparin 30 units international IV stat, followed by 10 units per kg per hour to keep the APTT, what we have to maintain the APTT 1.5 to 2 times above the normal, 2 times of the normal. Okay, you can maintain that, and you can give low molecular weight heparin over the over unfractionated heparin, and if low molecular weight heparin you're using, you can give 1.5 mg per kg per day subcutaneously 12th hourly. All right, and the last, this is the last. Okay, this is the last, that is maternal swallowed blood syndrome, that is isolated altered gastric aspirate. In this case, you will give a nice stomach wash. Okay, you will give a nice stomach wash with NS. No need to make it cold, please. No need to make it cold. Normal NS. All right, normal NS, normal temperature. Please give a stomach wash. Need not warm it, need not heat it. Okay, please. It's a baby. Don't forget. There's an altered. If altered aspirate continues, you can go on to do further studies like platelet count and coagulation studies. All right, coagulogram can be sent. Okay, and if platelet count and coagulation studies are normal or stress bleeding is suspected, you can give IV ranitidine. IV ranitidine can be given at 0.5 mg per kg per dose. BD for term, preterm. Sorry, preterm it's BD 0.5 mg per kg per dose, and 1.5 mg per kg per dose TID for term babies. Okay, IV ranitidine can be given. Okay, so this is about the overall overview of approach to a bleeding neonate. I gave you a case scenario of a DIC which I have seen in my case. Then I described in detail about the history, examinations and investigations, what can be done in the in a case of a bleeding neonate. Okay, and some important associated systemic findings, syndromic findings and investigations. First, rule out maternal swallowed blood syndrome and your checklist. Okay, and please do refer to the normal hematological values, hemogram values in a neonate, which can be term or a preterm, by standard textbooks of pediatric hemato-oncology. And you have to know a little bit about the managements. That's why I have included how do you manage like prevention and treatment. Okay, and I have given some details about platelet transfusion and Ffp transfusion, and little bit about management of immune thrombocytopenia and DIC and isolated gastric aspirate. So a very big thank you for you. Thank you for listening to my class. Now the sources of this class, references, if anyone wants to know, because everyone wants to know what are the sources. So my first one was Lokeshwar, which is a textbook of pediatric hemato-oncology, and we have something called as PGI NICU Blue Book. Okay, so sorry, NICU Blue Book is there, and AIIMS protocols and JIPMER protocols. Okay, these are my 4 references for this presentation. Okay, so you can refer to these, and thank you very much. This is my class ending approach to a bleeding neonate.